Yeah, dude. Well, my goal is to, as you might have detected, kind of increase the assessing we're doing, both the testing and stuff, so I can find out how to talk to you about the things we know you don't know now, because talking about things you know is wasting everybody's time, or at least wasting more time than it should. So we're gonna move through some stuff. Dude, I'll say it over and over and over. You should go to chapter 18 and read the whole thing. Take your own notes. Use my slides or my lecture as a way of highlighting that. Today's kind of designed around the anatomy physiology idea, and then if we had time, we get into electrophysiology and tropic hormones, and then the next day or Thursday, I ideally wanted to spend a bunch of time talking pathology, meaning heart attacks and all this stuff. I don't really know how all that's gonna go, so the first quiz is basically just anatomy physiology stuff though, okay? Regardless of where we get to today. Whatever it is, we'll be finishing up on Thursday. All right, here's what we get as a reminder. Here's what we get from the NHTSA to say, here's what you should teach EMTs. We teach the EMRs to just have, I forget what the S stands for, but just some understanding of chest pain. That's what they say. Teach the EMRs some understanding of chest pain. And then we move over here, we don't just teach about chest pain, we teach about ACS. And the F means fundamental understanding. So I had to make sure the EMTs, you as EMTs, had a fundamental understanding of acute coronary syndrome. What did we change when AEMT? Well, now you have a complete understanding of acute coronary syndrome. And the medics is much the same. It's like a complete and whole understanding. I'm like, okay, you could teach a 5-hour lecture on ACS. It's just 3 words. What in the world, right? So I'm gonna do my best to kind of highlight all the things I value. And I want to remind you as well is, even though they're not giving us like obvious, like they should know this stuff, we had like a 95% pass rate on our last AEMT class. So what we're saying is working. What we're saying is what you need to do. My suspicion is it's way more than you need to know. But I don't know a better way to do it. I'm like painting a wall with a bucket. All right. So other than that, there's not a lot of major associations. It's the exact same material, but it's just saying a deeper understanding of that. And that's largely what AEMT is. In fact, there is more of a difference, in my opinion, about what happens when you move from EMT to AEMT than there is from medic, or AEMT to medic, right? I mean, if we consider what are the interventions that an AEMT can do that an EMT cannot, airway interventions, we're talking about end tidal, supraglottic airway, tracheal suction, and some meds or whatever. Okay, well, what can a medic do on top of that? Well, intubate, I guess mag sulfate.
100 times more than it is.
For airway? Not really.
Oh yeah. Needle decompression.
Needle decompression. So I'm like, so the medic class is largely anatomy, physiology, fundamentals of da-da-da-da, and it's all just kind of repeating itself, because basically the EMT is where you get really introduced to new stuff. Hey, by the way, it's not just a heart, it's also vessels. And AEMT, again, to remind you, is like, hey, remember that stuff we said? Now you have to know it. So let's kind of go through that. We talk about acute coronary syndrome. Essentially, this is our chest pain or coronary related stuff. In fact, you'll even hear people said, well, I had a coronary. And what they mean, of course, is some type of heart attack. And so we're referring to the coronary vessels when we talk about ACS or acute coronary syndrome. Most aspirin drug cards say not chest pain, they say ACS suspicion. I've been on the fence about changing that for the AEMTs. We have both angina and myocardial infarction, of course. Angina is largely the vessels themselves corroding. I just talked to a buddy that does a lot of cocaine. Just like last week, he was like, well, I like stimulating some cocaine because it makes me feel good. And I was like, yeah, no doubt. I'll never do cocaine because it's so dangerous for you. And he's like, what? Why is it dangerous? I'm like, well, because it turns your vessels into sandpaper. Cocaine causes atherosclerosis. And he's like, so it can cause heart attacks? I'm like, not directly, but it will goof up your vessels, and your vessel, next time you eat a cheeseburger and your body pitches out all the plaque, it'll stick in you because your vessels are goofed up from cocaine. And he was like, whoa! And then went and did cocaine, so I don't know, whatever. But myocardial infarction is, of course, a blockage, not specifically a vessel issue unto itself, though one can cause the other. You want to make sure that you understand phrases like mediastinum and what exactly that encompasses, this area here that encompasses the great vessels, the trachea, and the heart and the like, that's that shifting place. We will refer to it when we talk about pneumothorax and the like, about a shifting trachea or tension on the mediastinum, reducing blood pressure. We'll need to know the difference between, I can show the picture here. Make sure that you're able to differentiate layers of the heart. That myocardium is the muscles, right? That it's the squeezy part. Knowing that there is a pericardial cavity that it surrounds the heart because of the pericardial sac. I think it's important to know that there's 50 milliliters of fluid on average in the pericardial sac. What is pericarditis? Inflammation of the pericardium, yeah, or specifically the fluid in the pericardial sac. Can you hear it? Does it have a sound to it?
Probably.
That'd be the muffled.
That'd be the plural rub?
Yeah. Well, plural rub would be lungs, but you're not far off. It still sounds like, what did you say?
Muffled, that'd be the muffled right there?
That's going to be largely indicative of tamponade because the fluid in there is so thick, but you're not crazy. I'll bet that, like, on a test it won't say that, but in real life it'll sound quiet for sure. But it's usually like a pleural friction rub, that kind of sound. I don't think so. And here's one of the reasons why I'm not super familiar with it, even though today we'll talk about heart sounds. I never once in my entire career listened to heart sounds. Like, it just never gave me evidence that I needed. I only knew it for registry, so I just don't have a lot of familiarity with it. I didn't find that my clinical ability or my treatments were changing based on it. All right. There's a trick in here which falls in regards to the epicardium. It's also the visceral pericardium. These are interchangeable words. It's all depending, how we phrase this is depending on, you know, the point of perspective of the story. Since this is the pericardium, that layer that covers the myocardium essentially is called the epicardium, but also the visceral pericardium. So make sure you know that distinction. Does anybody know how pericarditis looks on a 12 lead?
No.
You're gonna make terrible medics. In short, pericarditis looks like a heart attack in every major coronary vessel. Why is that? Why do I look at a 12 lead and I'm like, whoa, you're having a heart attack in every possible location in your heart?
No, but I'm assuming because that fluid is pretty pressure,
Everywhere.
it can't really.
You have a problem everywhere because the pericardial fluid is encompassing the heart, right? Realistically, 12 leads are just like, I shoot a beam of electricity through you, and in a normal heart, it goes straight. If I shoot that beam of electricity through you, and it goes to non-conductive tissue because it's dead or inflamed, it'll have to go around it. And so really, if we see our straight line or normal presentation, we know that it's not having to go around dead tissue. Whereas if we see that line deviate, we know something is wrong. And if it deviates in all points, if I am taking that beam and I put it through this way, and this way, and this way, and this way, and that way, and this way, or a 12 lead, and every one of them is showing deviation, we now have a suspicion that you have a problem all around your heart. What is a heart attack, right? It's a blocked vessel, yeah? What are the odds that you're fine and suddenly get a blood clot in every single one of your coronary vessels at the same time? No way, right? And so our conclusion might be that pericarditis, because it's inflaming the entire thing. We'll need to know these things, right? If any of these words are unfamiliar and you're not sure what their purpose is, what do we know about the atria? What's the purpose of the atria? It's to, what's the purpose of the atria?
Which one?
Either one. What in general, atria being plural. Trinity, what do you got? Overfill the ventricles. Why am I emphasizing overfilling? Starling's Law, baby. Go watch Silence of the Lambs, right? Agent Starling, stretched skin,
I will not be open.
right? Tucked, taped, right? I only guess the fact that we didn't get a lot of laughs or a lot of, I can't believe you would say that faces. We just haven't seen Silence of the Lambs.
I'm thinking y'all must be too young to see, because even when I saw it, I was too young to see it when I saw it. Oh my god.
We need to be able to differentiate AV valves from semilunar valves and their location. We need to be able to trace a drop of blood through the heart, right? Got questions coming. Hey, a drop of blood is moving out of your right atrium. Where is it going? these kind of things. Moving from your left ventricle through which valve to get to so on and so forth. You need to know those things. What's stenosis?
Narrowly or?
Narrowing, very good. Right? We traditionally see narrowing occurring on the aorta, but it can really happen anywhere. I don't want to go into too much detail there. Make sure that you understand. What's another name for mitral valve?
Pulmonary?
Bicuspid.
Yeah.
Right? Because as you can see, it's 2 instead of the 3. I've heard these referred to as semilunar because they look like half moons. I don't know if this picture is non-representative, but no, I don't see that. I mostly remember, if you said which are the semilunar valves, my brain says, okay, hang on, which are the AV valves? Okay, now I know the semilunar valves because the AV valves essentially are going through the pulmonic and aortic system. Oh, sorry, that's completely backwards. Okay, sorry, completely backwards. AV valves are atrioventricular valves, so I have to think of it that way. Make sure you do a better job than I do distinguishing those things. And it's mostly just because the language changes. Sometimes they'll say, which of the following blah, and the answer will be tricuspid, which of the following blah, and the answer will be a semilunar valve. So, or I guess the more appropriate one, which would be aortic or whatnot. So we call them AV valves because they move from the atria to the ventricles, and that's kind of how I have to remember it, obviously not too well. And then semilunar valves are going both to the lungs and then to the rest of the body. When we talk about stenosis, what I mostly need you to know is if stenosis is pathological. It's good for you to know that it means narrowing, which can mean all kinds of different changes. It can cause regurgitation because the door doesn't shut too well. It can cause hypertension issues. It can cause murmurs. In fact, a murmur is often the result of having aortic stenosis, or rather valvular stenosis, because again, it's not just the aortic valve that can do it. To be honest, I don't know why it's the aortic one that's usually the problem. It probably has something simply to do with, no, I don't know why it would be aortic is always the issue. Why, if all of them can get stenosis, why is it most commonly the aortic? The only thing I can think of is that we only usually detect it here because it's the highest pressure system. I actually don't know that, it has never occurred to me. One of the things I want to mention here when we're looking at this is we can see the valves opening and closing, and that is what's making the sound of the heart. I think more often than not people say, well, the lub-dub is like lub-dub, it's the atria squeezing, and then it's the ventricle squeezing. If anything, that's backwards. And what we're hearing is not specifically the contraction of the heart, just like you can't hear my biceps squeezing. What you're hearing is the closing of the valves. And so when we start, and what we call S1 is when the ventricles are contracting to push blood out of the heart. And what we're talking about literally is just putting your stethoscope over a patient's heart and you're hearing it beat. Boo, 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 boo. Well, that first boo, which we often, in language, an onomatopoeia refer to as lub. So they, in language or in written form, they would describe your heart rate as, or heartbeat as lub-dub, lub-dub, lub-dub. And that lub is not the ventricles contracting, though that is what's happening. That lub you hear is your AV valves closing, slamming shut as the pressure puts force on them and expels blood out of your body. Naturally, as the ventricles are contracting, the atria are relaxing. Oops, I have it wrong here as well. That says semilunar valves, and that's not accurate. Right? So, of course, this is your semilunar valves opening because your ventricles contracting is pushing blood out to your pulmonary system and to your body. So what we're hearing, that lub, is this. And when you get this like wrong on testing, it will be because you're so used to thinking blood starts in the atria, then it goes to the ventricles, but we count the sound from the valve, not the chamber. Naturally then with S2 sound, this is the dub. Whoop, 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 whoop. This is the dub, this is down in diastole, this is where the atria are contracting now, and it's pushing blood into the ventricles, which means your valve up here is slamming shut. And so our AV valve is opening, it's pushing blood through here, and that dub, the love dub you hear, is the sound of that valve slamming shut. Or, to be honest, it might be the sound of the blood slamming against the closed valve. Either way, we're talking about the valves, not the squeezing of the heart. So I tried to boil this down essentially into its most simplest language. You should know that ventricular contraction is systolic blood pressure. I'll ask questions like, during which of the following sounds should you suspect the highest pressure in your vessels? S1, S2, S3, S4, and you'll be like, well, which one is the ventricles and causing systolic blood pressure? I didn't teach heart sounds last year. I may regret teaching it this year. I never valued it in my career, and I don't know if anybody got any registry questions on it. But here's the most important thing that I can think of. S1 and S2 are the only ones that you should be able to hear. If you get a test question where it says you can hear S3 or S4, you should know that they're trying to indicate to you a major problem, maybe heart failure. That's probably enough. So be careful on how deeply you memorize this. I really think this is not one, but at least 2 steps farther than you need. My heart is normal, therefore I hear which sounds? S1 and S2. S1 is the ventricles collapsing, causing blood to hit the back valve of the AV. The dub is the reverse, essentially, or the next step. S3 is pathological in adults. If you can hear S3 on an adult, something is wrong. Specifically, it refers to when the diastolic filling of the heart is happening too fast. We call it a gallop because the valve is kind of vibrating, because it's just happening too quickly for it to close completely. Even now, I regret telling you all of that. S4 is an atrial gallop. Do I think you're going to get a question asking you, S3 or S4, which of these is an atrial problem? No, I don't. But if you can remember, essentially, that S2 is where the atria are squeezing, hopefully you can remember that S4 is the atrial problem because it follows S3. Unlike the valvular issues, the S4 is specifically referring to being able to hear the atrial contraction. Again, I don't care that you know that. In fact, this is what I think you should take away from that. The S1 and S2 are the only sounds you should hear when listening to a heart, and if you hear S3 or S4, this indicates heart disease. You should know that they call those gallops. In practice, you'll still hear S1 and S2. That's how normal hearts work. If you didn't hear S1 or S2, this person is dead, probably. Their pressure is probably too low to make a sound. So how it would go is not just lub dub, but lub dub, I don't even know what they use now. Dub D or something like that. There's like other onomatopoeias in there. Lub dub dibbity or something. We used to say Kentucky, Tennessee, like whatever, dude. I never even saw it on a medic registry. Anybody need more of this? Yeah, dude, I wouldn't write anything down here. I'd write the next one down.
Pretty much just said S3, S4, bad. And then just
S3, S4, bad. 3 can be normal in pediatrics, but, you know, it'd be a shame you go to the test and you're just like, man, I know so much about differentiating S3 and S4. What's pericarditis again? Like, no.
No child, no.
Again, we need to be able to memorize the drop, to trace a drop of blood. Remember, there was this class, right? We stood everybody up and had them get in a row. That needs to be bread and butter for you. You're gonna get such easy throwaway questions like, where's this drop of blood going? Or your patient took a bullet through here, so what is that preventing? You need to understand the fundamental anatomy of these things. Also be aware of the tricks there as arteries go away from the heart, so the pulmonic arteries and whatnot are oxygenated versus deoxygenated concepts. Does that make sense? Do we remember that?
Mm-hmm.
That not all arteries carry oxygen is, I guess, what I'm saying? All right. What about this? Do we know where the majority of your blood is housed? Sure, in your body. Where specifically? Not in your belly.
Isn't it
Liver's got a decent amount. I think the numbers might surprise you.
There's like a thing.
Tony, what do you got?
I'm thinking kidney.
Kidney is another good guess. This is systemic, right?
Is it your lungs?
65% at any given time, 65% of your blood is in your veins.
Oh.
In fact, the far and away, vast majority, so it depends on your kind of description, because you might be saying, hey, liver and stuff, hey, a lot of blood is going to those things. But of course, your blood doesn't, the main reason why I wanted to bring this up, it goes back to our bronchial discussion. Your blood does not exist outside of your vasculature. Therefore, it's not in your kidneys, it's not in your stomach, it's not in your brain. It does not exist in those places. And in fact, if your blood exists outside of your circulation, you got a major issue. Intracranial hemorrhaging, or Have's syndrome. That's your blood escaping the vasculature. How is it then that our liver tissue, or our spleen, or our kidney, how is it that they're getting nutrients and exchanging gases if none of the blood is leaving the capillaries? Well, because it's crossing the walls, just like our alveoli, right? We're not getting blood in our lungs. Our blood is getting close to our lungs and the capillaries, and then gas is exchanging across the wall. What this means in part, if you note, we have the heart chambers. What's actually being squeezed out of the heart is actually very little at any given moment. It's a lot over time. It's all of it over time, right? And that 10% of that exists in your lungs vasculature. I just condensed it because this could be further broken down into capillaries, arteries, and veins. What I'm saying to you is that a huge portion, 85, is that right? 85% of your blood exists in your systemic circulation. So if you get a hole in your systemic circulation, you're going to lose blood fast. We talked about the layers of the heart. We need to know the layers of our vessels as well. Veins and arteries are essentially the same in makeup, except for one thing. Does anybody know? This is by definition, though I don't know that you could tell this, but this is my representation of a vein. If I wanted to show you an artery, what would be different? What do you think, Trin?
I was gonna say valves at first.
Hmm.
Arteries don't have valves.
That's a good point. Yeah, that we find the flow valves in the veins. And so maybe you'd be inclined to say, this might be an artery because you don't see valves, but
And then I'm pretty sure veins have a thicker tunica media too.
why would arteries
Oh, arteries.
arteries have a thicker tunica media? First of all, what is the tunica media? It's like our myocardium, right? It's muscular. Why is it? Why would we, if you got to pick right now with a magic wand, hey, I get to make one of yours thicker and stronger. Do you want it to be your arteries or your veins? Why would I say arteries, please? Which one is higher pressure? Arteries by a long shot, to the tune ideally of 50% more, right? Because what is in a perfect scenario, what is the pressure in our veins? It's a number, and we all know it. What's the pressure in our arteries?
I might be confused on the question.
What is the blood pressure?
120 over.
What is your blood pressure in your arteries over the blood pressure in your veins? 120 over 80, right? And so if we've got almost double the pressure, right? 80 would be 160, almost double the pressure. We need it to be able to handle that, or else you'll have blown vessels, right?
Would be really.
So the tunica media, essentially, the muscular part, the squeezy part, is much thicker in the vessels. What I would try to remind you, essentially, I remember this as time. Tunica, I-M-E, and you just move out, right?
Intimate, close,
Sure.
medium,
External,
middle.
intimate, circle, inside. Also make sure that we know lumen. Where's another place we hear the word lumen?
Airways.
Airways, right? In fact, it means any opening like that, right?
And we call it Harry Potter.
Or in our combi tubes and the like.
Yeah.
Did you say Harry Potter?
The like two.
Professor Lumen.
I mean, yeah.
All right. Just a quick perspective of this stuff. That means that at any given point, approximately 3.25 liters is in your veins. These sound like test questions. They're not. I don't care that you know how much is exactly where. I care that you know as clinicians. That's a lot. It is a lot. It's a ton. What I mostly am trying to get across is that these are the places that your body, where blood happens. So if we're giving alpha agonists and vasoconstriction, it's affecting these things. It's not affecting it's not affecting any of the blood outside of that, because there should be no blood outside of that. All right. We also need to talk about coronary circulation. Coronary arteries, of course, referring to the ones, we have two concepts here. We have blood in the heart and blood perfusing the heart, okay? And both of those are very important. First of all, how does the heart perfuse itself? Where does that come from?
Coronary artery.
A coronary artery.
After at least say aorta.
That's right. Just off the aortic arch, essentially. We can even see one right here, coming immediately off the aortic arch, right? Or sorry, the aorta, I should say. And this one coming off the other side. What that means is that you have to be careful in some of the language there about blood and heart. You have to ask yourself, is this blood fueling the heart, or is this blood being pumped by the heart? Those are very different things, right? And when we talk about having a heart attack, of course we're not talking about in the chambers, we're talking about these coronary vessels being blocked in and of themselves. And much like a garden, us watering a garden, if we have enough water and that garden grows, that's fine. But if we block the hose, that area of the garden will die, right? And that's going to change all kinds of things for us. Now, there's a million different names for this stuff. I try to do the most simplest version of this, and I say that you essentially need to remember 4 names. You have to know that there's the RCA and the LCA, the right coronary artery and the left coronary artery. Which one, by nature, is bigger, left or right? Left. Why would the left one need to be bigger than the right one? Say it again. It's the larger side of the heart, therefore needs more perfusion. Yeah, well done. In fact, the left ventricle takes up something around like 70% of the heart's, I want to say mass. I hope that's true. 70% of the heart is the left ventricle. That's what I will say. Circumflex artery, so called because essentially it wraps around the back side of it. There is a portion that when we do a 12 lead to look at a patient's heart, we can't see it. Right? But naturally, I don't know what the back of your head looks like when I'm looking at your face, and so too if I put a 12 lead on the chest, I'm not looking at the back of your heart. So there's a portion of this that we don't see even on a 12 lead. You shouldn't be surprised. What do you suppose is the solution to seeing the backside of your heart?
Put it on the back.
You do a posterior 12 lead, or a 15 lead as they call it.
So those would be exactly.
What do you mean by,
Like,
nope. So I don't know if I did it, but I thought about today making one of your lab activities to place on a mannequin a left-sided 12 lead.
Oh, I've seen left side. I've never seen back side. Would that be that?
Nope, it's just changing the angle. We're no longer just looking kind of straight at the heart. We're starting to look way more at the right ventricle if we did a left-sided 12 lead. Or right-sided, I should say. A right-sided 12 lead, not left. Because naturally, the left-sided is the standard. We go across the left side, so you can do a right-sided. Will we get into it? I don't know.
Maybe.
We do poor man's right-sided 12 leads in the field. Basically what happens is we look at the left side of the heart because that's 70% of the ventricles. The fact that we can only just barely see the right side of the heart and can't see the back, we care less about that because the twist of the heart is showing us most of its muscle, right? The only time that any medics are really doing right-sided 12 leads is when we have a suspicion that there's a heart attack over here that we can't really see. And so if I do a left-sided 12 lead, essentially, that curves down or under here, under your left pectoral, if I suddenly need to be sure of what's going on over here, you could just by nature reverse these two and switch it over here, and now your angles are all coming this way. But what we really do in the field is we just move V4, that's it. Because V4 looks basically exactly where we need it to. So you'll hear medics say, oh, I did a right-sided 12 lead. They probably mean they just took V4 over here in its exact counter spot and then ran it again We call it V4R to look at that stuff.
Oh.
To summarize why we would even do that is because traditionally we don't give nitro, or we are cautious in giving nitro to what kind of patients? Patients with low blood pressure. There's even our overarching concept that could govern that. Low preload, right? Well, where is our preload occurring? In large part, it's over here. So what'll happen is we'll see a patient, we'll have a suspicion of a heart attack over here, and I'll say, let me do a right-sided 12 lead real quick to see if I even should mess with nitro or not. I'll just look at this area and see. And so many times I told the doc, they did say chest pain, their blood pressure was fine, they had no contraindications, but I put on V4R and I didn't like what I saw there, so I withheld nitro. Again, it's not your job to interpret 12 leads. But what I want to show you is that this is up here, this is a 12 lead, and of course it has 1, 2, 3, these are our 1, 2, and 3 leads. And we have AVL, AVR, and AVF, which are our augmented leads. And then we have V1 through V6, which are our ventricular leads. And so basically, if you remember, limb leads go on the limbs, 1, 2, 3, and then the neutral, right? That is kind of looking at the heart this way, through this plane. And that's where the natural electricity of the heart goes. It goes from my right hand to my left foot. This is what we call normal access of electricity. Right? It goes this way from the SA node all the way down to the bottom, right? Whereas the ventricular leads are here and therefore looking this way at the heart at different areas. And so we're just kind of trying to get this view of what exactly is going on with the heart. And so you can see here, if we have our right coronary artery going over here, that's associated with 2, 3, and AVF specifically. You don't need to know this, okay? What I'm trying to show you is that you can get to a point of understanding 12 leads where it literally correlates to the place they're having the heart attack at and how that might affect certain things. Here, for example, is the lateral side. Whereas before we saw the right coronary artery, now we might be seeing the circumflex because it's really the view we have, of course, just with our, I just have to do it because I'm usually sitting next to patients. Right? If we have the 12 lead on, it's only showing just the side of it because, of course, our vision is like this. So it's only going to catch the tail end of that. And as it wraps around, it can even catch over here as well, but it's all the lateral sides. Again, you don't need to know this specifically, but what I'm trying to show you is you can look at a 12 lead and know where that clot is, know where that dead tissue is based on the representation of it, right? It's like water flowing down a path and you put a rock in that path and now it has to flow around. That's what a 12 lead is. Now we're not looking at perfectly straight lines, we're looking at a series of squiggly lines, but what we can start to do is associate these squiggly lines as normal when they look like this, and when they deviate, they're flowing around dead tissue. Finally is the septal leads, shown here. So if I see a suspicion of a STEMI or a heart attack here in my V1, I should never assume that I've got an issue over here, because I can associate those areas with that. Does anybody know why we call a septal infarct the widowmaker? What does that mean? What am I trying to imply by saying the widowmaker?
That's the
You're
high-
super dead.
Okay, coming back.
The high likelihood.
The amount of times that a medic will identify a septal infarct without cardiac arrest are minimal. Because if you get a blockage there, you're dead. Why is that? Why might that one be particularly dangerous? They're all important, right? What do you think, Trin?
It's right over your left ventricle.
It's the primary perfuser of your left ventricle. It's not good. I mean, can you live without appropriate atrial function? Atrial fibrillation is just that. It's not good that you have an inferior infarct. You can die from that. But if you get one where your left ventricle is no longer being perfused, you might be toast. And that's why we call that the widowmaker.
I think that's actually what killed that celebrity from Friends, was a widowmaker in particular.
And all the drugs he's been doing for the past 20 years.
I'll hear none of it.
Love Matthew
Bad
Perry.
genetics.
Love Matthew Perry, but he was a drug addict.
Yeah, drugs are bad.
Yeah.
Um,
He was doing good for a while.
So it's important for you to know these things. We just mentioned I don't need you to associate 12 leads. In fact, I would encourage you not to think that way. If at any point you're like, actually, I think it's an inferior infarct, you're probably going to make your medic hate you. Even, because this is what I said, Mr. Harris was the one that I used to say this to when he was my EMT, right? I was always like, okay, even when you're right, it pisses me off because you have no skin in the game. He's like, obviously pulmonary edema because of inferior infarct here, obviously. I'm like, okay, it's real obvious to you because if I give the wrong med and he dies, you don't get in trouble, I do. So it's all so obvious to you because you have no skin in the game. And so even though he was usually right and a good clinician, it's hard to value somebody's opinion. It's hard to value an EMT or AEMT that knows cardiology and will never take the fall for not being correct. So that's why, again, I encourage you, let's be smart, let's be clever, but just know that it's hard to value some. You tell them the right answer enough, they're gonna believe you. You know what I mean? You can be helpful here, but it's not in your scope, and it's really hard for people to get good at this when they don't get punished when they're wrong. You should know that if nothing else, you should know that the LAD primarily perfuses supplying blood to the left ventricle. That is perhaps the most important coronary artery aspect to understand. I also would expect you to understand how they are all wrapping around the heart. So if I said to you, your patient is having reduced perfusion of the right ventricle, which coronary artery is being affected, you should say,
Left anterior descending. Wait,
right ventricular perfusion issues.
I just completely blocked out the first portion of what you
Sure.
said, and I was like, wait, hold up.
Your patient is having a lack of perfusion in the right ventricle. What is the affected artery?
Oh yeah.
Right coronary artery. Very likely. Okay? Those kind of questions, those kinds of anatomy things. Before we were just like, hey, pretty pumpkins, just know that there are different coronary arteries, where I'm like, you need to know their names now and what their job is.
And where do they get?
Ideally, we spent some time kind of knowing at least, well, I don't really remember where they went, but right and left are pretty intuitive. And the left one's bigger because the left ventricle is bigger. And so that one must split. And one of them's got to go to the back. And if one of these arteries has to go around the back, it's probably the one that's bigger in the first place. So. I think we're pretty good on aortic aneurysm and thoracic aneurysm stuff. What does it mean to have an aneurysm? If I said, my guy's got a AAA, what I'm saying is it's an abdominal aortic aneurysm. What does that mean?
It's the ballooning of the.
The ballooning.
abdominal
I
aorta.
think this class really kind of got that nailed down. And in fact, what should you be suspicious of? Like the raised hand for this. Your patient has a aortic issue with a blood pressure of 120/80. What should you suspect? An aneurysm, a dissection, or a rupture? Or maybe I can help you by saying, you checked blood pressure in your left and right arm,
Oh yeah, it's different.
and they are identical. What should you suspect? An aneurysm, dissection, or rupture? Well, what would we expect for the rupture? What kind of vital signs might I suspect with a rupture?
Low blood pressure.
Hypovolemia, low blood pressure. I got a hole in the #1 biggest artery in my body, the highest pressure area of my body. That's going to empty blood pressure like crazy, right? The aneurysm puts odd pressure because a lot of times we get aneurysms up here where these brachiocephalic arteries go, and why we have differences in blood pressure from one arm to the other is because we're not going to have it in a AAA specifically, but if we've got it up here, an aortic aneurysm, and it compresses that first one that goes to your left arm more than it compresses the right one, see what I'm saying? Whereas a dissection isn't going to affect the changes. So we might expect compensating type vitals for dissection. We might expect decompensated or refractory, irreversible for rupture. And we might expect difference in the arms if it's an aneurysm. Okay, that is like 100% registry type questions. Your patient has such and such blood pressure. What do you suspect? We talk a little bit about the vasculature here. I think this class does okay on this as well. Mallory Weiss versus Borjaves. One is a shearing force, having the interior kind of rupturing. Sorry, what do I want to say? Not rupture. Dissecting, and the other one is a full-on rupture. One is worse than the other. Can you die from Mallory Weiss?
Yeah, eventually.
Mallory Weiss tear, you can. But again, much like Lucy and I were discussing, if I had to pick one, I'd be looking at the vitals. And if the vitals were really bad, I'd err on the side of Borjaves because it's a big old hole, right? I don't know if that's true. That's what we're just gonna move by. Wait, does it say dissection? Yeah, I'm not sure that it's true. I guess actually it might be. If I had a dissection that was up there as well. So, okay, or before I said it's aneurysm and that's a differentiating fact, but I suppose it probably, I don't know this, but it probably can be dissection just like the slide says, but instead of compressing it, it's preventing blood flow in that area. Meaning if I have blood that is going out to my body like this and I have a problem right here, oh, that's a little bit of a misleading thing. This one's going to my head and arms and I have an issue here, we should suspect that this one is going to be lower blood pressure, whether I have a dissection or an aneurysm there. So hopefully that makes sense. I hadn't considered that. We need to know the makeup of the bloods, If you don't know these fundamentals, you need to know this for sure. Obviously, red blood cells carry tissue on the hemoglobin. Living for 120 days is important. I've seen that on the registry, absolutely. The other bit we want to get into is our hematocrit and hemoglobin. This is new for us, I think. Is this new for us? Hematocrit and hemoglobin? Anyway.
I think.
It's the rules of three. This is what is telling us basically how capable your body is of transporting gases in your blood. A nurse or a doctor or a test question is going to say, your patient's H&H is this.
Thank you.
Your blood cells are blah. Your hemoglobin level is blah. Your hematocrit is X percentage. I'll be honest, I do not remember cells per millicentiliter. I don't even know what that means. Okay, maybe it's an error. The grams per deciliter, I do not remember the nomenclature, just that this one, that hematocrit is percentage. That's what I remember. And how I order that then is like 5, 15, and 45. If you can remember 5, 15, 45, and you can stack it E to H here, you can remember that on average, if I see erythrocytes that are like 3.2, I'm like, whoa, that's low, because it should be 5. They're like, well, what about hemoglobin level? I'm like, well, it should be 15, 5 times 3. I'm like, this guy's is 12. I'm like, whoa, the hemoglobin level is low. Microliter, thank you. More to the point of how little I remember those actual nomenclature, or that actual nomenclature. So I only say this to you, we'll basically never have this knowledge. I can't remember who I was talking to about it last time, but this is one of those things that would appear on like interfacility transfers or on test questions where somebody's drawn labs and said, hey, 2 days ago when I drew labs, this is what it was. I'm suspecting that this patient, well, if these were low, let's just say your patient's H&H is low, what should you suspect? Well, if I said I have a cup behind my back, and it's low on fluid, right? You might have to determine, well, did you not pour much fluid in there to begin with, or are you actively pouring it out now? And the same is true here for H&H. If your patient's H&H stuff, hematocrit and hemoglobin, if it's low, then either your body is not making this stuff like it should be, or you gotta bleed somewhere. And it happens all the time where they just run normal labs on interfacility or long care patients and they notice that their percentages are low or their H&H is low, and they start to suspect they might have a GI bleed or an ulcer that's bleeding. And so they want to get them into the hospital and you might be transferring that patient. We talked a bit previously about the electrical conduction system. If I said intrinsic rates of the heart, do we know what that means? What are the intrinsical rates of the electrical conduction system? Well, we all instinctively know the intrinsic or natural rate of the SA node is 60 to 100, which is the normal heartbeat, right? And as we fall down the chart, we start to lose its capability. We'll move down the chart where suddenly the AV node is not 60 to 100, it's less than that, 60 to 80, let's say. The bundle of His and Purkinje fibers are now 15 to 40, right? It's decreasing. Why is that actually a good thing? Why is it important that the bottom of our heart, the electricity down here, does not become more powerful than the top? Say it again. It is too much. If Lucy and I are both holding a copper wire, and I make it so that electricity can go both ways, we're both getting shocked, right? What I'm saying is that if all of the heart is essentially a muscle with an electrical wire through it, let's just say, what we need is atrial contraction to cause overfilling of the ventricles. If this were beating stronger than the top, it might reverse. And so it's natural that we see a degression or a lowered intrinsic rate as we get farther and farther down the chain. Who's this? Beethoven with an E? Einthoven. Now, I'm not saying we need to know all the normal axes of the heart, because in fact, all these are relevant, right? But if you remember my exercise on it, I always start with just pointing down both fingers to your left foot. That means that's where our positive electrode is, that left leg. We smoke us a cigarette and we throw it this way because smoking is simultaneously bad for you and super cool. Meaning, in our left arm, or lead 1, we have positive and negative. It's kind of good, it's kind of bad. Now, obviously, this isn't talking about good, bad stuff. This is talking about how the electricity moves and then the deflections that we make for it. Put very simply, if we are going towards something positive, it will cause a positive inflection. Meaning, if I'm just shooting a line of electricity through your heart without a lead, I won't really detect anything. But if I put a positive lead down here, how do I want to say it? Like, this is the normal electricity of your heart. If I put a positive lead here, the electricity that I put towards that, that's an X, put towards that positive lead will then start to cause a positive inflection. So lead 2 essentially is looking in this direction, and then when we go at the positive lead, it causes. Now, if I had a ventricular issue, let's say I was in VTAC, so no longer is my axis going from the sinal atrial node all the way down. Instead, it's going from the ventricles, perfectly inverse. What do you suppose this might look like if it was going exactly opposite? Right? And so part of the understanding of EKGs in general is figuring out what the normal inflection is. And so, in fact, if we look at a P wave, Q, R, S wave, T wave, we can immediately see that these elements here, these things, these all must be going towards the positive connection. Okay? When we're talking about this, and what I need from you is less about the axis understanding, that's just kind of the groundwork. We are at a place where I need you to be able to identify where the P wave is, where the R wave is, and where the T wave is, and what those things are associated with. Now, I don't like the one word that they have on here, though I suppose it's somewhat okay in this context. What is atrial depolarization? What does that mean? Your atria is depolarizing. We look at the words of depolarization as discharge, and the words of repolarization as recharge. So as you can see here, we have atrial discharge of electricity. But we don't know if that's mechanical as well. We just can see the electricity. In the R wave here, or the QRS complex, we have ventricular depolarization. How would you know if this patient also had mechanical contraction? This right here is chemical, it's electricity, we can see it. How could you confirm? I say, feel a pulse. So we have to be careful in saying, if I said, hey Lucy, does that patient have a pulse? You should say, I don't know. Yeah, I don't know. You can't look at that and say they definitively have a pulse. Now I'll say this, they don't usually look that healthy if they don't have a pulse, right? That looks beautiful.
Electricity's doing really well.
It's doing amazingly well. I don't understand. However, it could be. And so that's like a number one metric, is because what this rhythm is pulseless electrical activity until you know otherwise. PEA, that's what they call it. It'd be an arrest rhythm unless you felt a pulse. So we have a P wave, which is atrial depolarization. That's the P wave, electricity going through the P wave, and you can see it starts in the SA node, it's going down in this angle, but it's going also across to the other atria. But it's going ultimately down in this angle, and that's that. Then we have essentially the QRS complex, largely governed by the R wave, which is showing that we have ventricular depolarization occurring. Now, do you see how this curves around backwards? Right? What we're in part talking about is, man, do I want to get into that right now? I think this is probably easier the more superficial we go. What I need your brain to know is that P wave is atrial depolarization, that the R wave is ventricular depolarization, and that the T wave is ventricular repolarization or recharge. Where does the atria need to recharge? I knew you know where. Does the atria need to recharge? It does, right? If everything is discharging or depolarizing, we also need to repolarize it. Where is the P wave's repolarization? Or the atria's repolarization? Why can't we see it?
Don't look at me.
We can see ventricular depolarization. We can see ventricular repolarization. Where is the P wave repolarization? Where's the atrial repolarization? Why don't we see it? Trend?
I'm pretty sure it's the R wave. I know it's somewhere QRS.
Yep.
But
You can't see it because it would exist here.
yeah.
And since we're just looking a singular direction, this is the loudest voice gets heard. So we don't see atrial repolarization because it's buried under the depolarization of your ventricles. They're bigger. They're making more noise, more electronic noise. So a little quiet. Is that where we want to? It's nowhere near as far as I wanted to get through. Let me look at the quiz and make sure that I don't mislead you and don't have to send a email regarding it. Mostly, I believe this quiz though is just anatomy, physiology, not electrophysiology. Well, no, there's probably some. Let me just look at it and make sure that I tell you what you need to know. Because I really want you to study the fundamentals before we go into Thursday and start talking about some in-depth concepts. Alright, I basically have what is a heart attack, blood filling up, layers of the heart, fluid in the heart, SA, AV, His, bundle branch, Purkinje fibers, circumflex arteries, coronary arteries in general, valvular discussion, trace a drop of blood through the heart. So yeah.
So a lot of anatomy.
So all anatomy, and then the only real questions there in regards to the electrophysiology isn't P wave, QRS, and all that stuff. It's really SA node, AV node, His, intrinsic rates, and that. So when you go into the quiz, you can kind of expect it's really fundamental anatomy of the heart stuff. But just know that if you're like, okay, then I'm only going to study that stuff. I'm not going to look into QRS complexes. I'm not going to look into sodium potassium pumps.